Good afternoon, and welcome to Impact Live, Under the Scope, Canada's Healthcare Workforce Crisis. My name is Lauren Cipriano, and I'm the Canada Research Chair in Healthcare Analytics, Management and Policy. Here at Ivey, I'm a professor in management science, and today I'll be moderating this important conversation on something impacting the lives of all Canadians, healthcare. Over the past 35 years, per capita spending on healthcare in Ontario has increased, but much of this can be attributed to the aging population. After age standardizing, the investment in healthcare has increased by less than 1% per year. Even though these demographic shifts of the aging baby boomers were widely known, we did not prepare or staff the healthcare system accordingly. For example, we have not invested in long-term care or home care resources. Over 15 years, we have seen a 20% reduction in long-term care beds per person over the age of 75. Recent announcements in new long-term care spaces only keep up with population growth in that number of people over the age of 75. In part by choice, and because there are no alternatives, individuals over age 75 are increasingly living in their own homes with complex health needs and in need of scarce supportive home care resources. Similarly, we have more family doctors per capita, but again, not if we adjust for the people who are using family doctors on average 8 times a year, people over the age of 65. The number of family physicians per person over 65 has decreased by more than 26% since the early 90s. The direct consequence, nearly 20% of Canadians don't have a family doctor. Some suggest that nurse practitioners are the solution to the family physician shortage, but the same math is true about nurses. Over the past 10 years, we've seen a reduction in the total number of nurses per person over the age of 65. In face of these demographic headwinds and the absolute shortage of healthcare human resources, today's panelists are managing and building real solutions within the Canadian healthcare system. With us today, we have Carol Young-Ritchie, Vice President of Human Resources at St. Joseph's Healthcare London. Wael M R Haddara, Chair and Chief of the Department of Medicine at Schulich School of Medicine, London Health Sciences Centre, and St. Joseph's Healthcare Centre. And Maria Mathews, Canada Research Chair in Primary Health Care and Health Equity, and a professor in the Departments of Family Medicine and Epidemiology and Biostatistics at Western, where she's a terrific colleague. Together, we'll take the next 45 minutes to reflect on how we got here, assess the current landscape, and explore tangible solutions to this critical issue. We'll also leave time at the end for your questions, so please don't hesitate to share your thoughts throughout the discussion. Let's begin. Our first theme will be shifting models of healthcare delivery impacting health human resources. So I'll start with you, Maria. Team-based primary care is being touted as a solution across many jurisdictions. What is the motivation and what evidence supports these models?
So thanks for the question, and thank you for inviting me to the panel. There's lots of evidence to show that when we have team-based care, we see better patient outcomes, better satisfaction, and better cost effectiveness. So part of this move towards team-based primary care is building on the evidence that we've had from the last 20 years. It also offers a way to expand capacity because if we involve nurses, nurse practitioners, family physicians, social workers all on a team and provide the support to allow them to work to the full scope of practice and encourage them to work at the outer boundaries of their scope, we have greater capacity to treat more people. We also kind of need to rethink when and where we need a family physician. So when I go in, I am generally healthy. Most of my care needs can be met by a primary care nurse, a registered nurse. And just like we would have in any other part of the healthcare system, if that provider sees that I need more care, that's when they would bring in a nurse practitioner or a family physician or a social worker. So rather than have a family physician providing services that could be provided by a nurse practitioner or a nurse, we're really encouraging the family physician to use their skills at the top of their scope of practice and really save that for the patients that need those specialized skills.
That's really interesting. And I think that same shift in team-based care has been core to hospital practice for a long time. Well, can you speak to that?
Yeah, no, absolutely. Again, thank you very much for the invite. It's a very important topic and one that's really giving a lot of people a lot of sleepless nights. So within the hospital system, the idea of team-based care is generally the rule rather than the exception. Teams of physicians, nurses, nurse practitioners, respiratory therapists, social workers, and I will obviously miss some important health disciplines if I keep going on. But we recognize that no one profession holds the key to the patient's wellness journey or illness journey. And so there is a relatively high degree of decentralization in the best teams in hospital care. So professionals actually make their own assessment as to whether they need to be involved. And that leads to fairly seamless and well done care.
Thank you. Carol, hospitals used to be the epicenter of the healthcare system, but now more and more care is community-based and delivered on an outpatient basis. The Ontario government and other governments are increasingly looking at home-based programs such as Hospital at Home. What are the impacts of these shifts towards outpatient care and hospital at home type programs on the human resources needs we need across the system?
Thanks, Lauren. I'm excited to be with you here today. And there's certainly, I think, what's at the forefront of our system is the value of our health human resources. And certainly, we need lots of health human resources. And different from, I would say, the years past, where the hospital was the epicenter, people have choices where they want to work. So I just want to highlight also that the community care, acute care, long-term care, they're all specialized areas of healthcare. And people have choices where they want to go. And through their career span, they might want to work in different sectors. So it's really important that we look at, and certainly as students are getting trained in their education phase, they're getting exposure to all these different areas. And certainly there's rewards in working in different areas. But it would also mean that we're going to need more people. And practicing to their full scope, as Maria said, is going to be really, really important that we value the people we have and make sure they can work to their full scope and flexible as things change, because we do know we're having a shift to outpatient. We're having a shift to virtual care, more in the home. So how do we shift with that, shift with our technology, and make sure we're using our precious health human resources to the fullest we can?
So if we're seeing, hospitals are doing team-based care within them, team-based care is the patient's best model in the community. Well, I go to you and I ask, do hospitals need to change the models that they use to support primary care? If we're going to have these team-based primary care models, should they be more tightly integrated with hospital and specialist systems? Because certainly we've all lived the experience of those being fairly distinct, broken, and really weak communication. Or is there room for improvement there in how we are developing those systems?
No, for sure. And I think the tension to that question is that we have come a long way from siloed care and the complete separation between primary care and, say, tertiary or quaternary care, but there's a lot still that needs to be done. In Ontario, the Ontario health teams and the piloting of that with certain disease conditions is well underway. And if it does work well, if it does actually get implemented the right way, it will go a long way towards bridging that gap between primary care. The e-consult system is also bridging an important gap where simpler questions or questions that don't require a full consultation can be addressed rather quickly. And so I think there is a lot of work that is being done in that area, but there is still a lot to be done. The integration of the electronic medical record in a truly seamless, user-friendly way is something that has not yet happened in many jurisdictions. That of course requires a significant investment and slow in the coming.
Maria, what does primary care need from their partners in the hospital care system in order to provide that fully integrated care and support, especially complex chronic health patients?
I think Will just hit one of the major stumbling blocks on the head. We do not have interoperable, accessible EMRs that allow the hospital and primary care providers to be able to see patient care. And patients are actually very surprised that their family doctor may not have the information about what treatment they received. Likewise, when a patient goes and sees a specialist, they're very surprised that the specialist doesn't have access to the information that their family physician has been gathering about them. And so, I mean, this idea that we have accessible EMRs that can be viewed by different parts of the healthcare system that follows the patient from provider to provider, I think would be, a great asset in improving the seamlessness of care between different parts of our healthcare system.
And transparency of that information to patients themselves.
Yes, patients have also wanted to be able to have access to their own healthcare information as well. So that's, having a portal where patients can have access to their test results, to their appointment standings. Those are also very important and would improve the seamlessness of care.
And so, Carol, I'll come to you for the last question of this round, but we're extremely efficient right now. So what has the impact of technology been on services, either at your hospital or what you've heard about from your peers? How are things like AI scribes, remote monitoring, virtual care, but also vital signs monitoring remotely? How is this affecting the demands on your healthcare human resources and the types of human resources that you need? Or is this just creating more information that actually needs more humans to interpret it?
Yeah, I think we've had a big explosion of that, certainly during COVID when we had to do things differently. So we've had a lot of rapid changes, and we're trying to catch up with those changes and how those changes can work. And what we saw was there were some of those technology solutions that worked really, really well. Another one is patient navigation. So lots of work's been done on how to navigate patients and help patients navigate through a system, particularly with complex needs, certainly in cancer care, with nurses who do patient navigation virtually and have a main contact to help that patient do that. So it's taking all those pieces, all those data points, and putting that together and helping the patient through the system and through complex needs sometimes. And how do we make sense of that? And how are we all sharing that information? So I think that's the exciting part. Like I said, we did have a bit of a explosion of needing to do things differently during the COVID, the pandemic. But it's catching up with that, and now what makes sense, and how is that impacting? We've certainly done consults in people's homes, which we know for the elderly, that's really helpful. That we don't need to bring the elderly into clinics and whatnot, and we get to see people in their home. So it's really evaluating that and evaluating the patient experience too. To how do patients find that experience, and is that working? So I think we're still working through that, but certainly lots of opportunity. And certainly lots of opportunity to maximize our health human resources with the right provider doing that.
Maria, do family practitioners find these technologies supportive of their work, or are they finding it more on they just add to the administrative burden?
So I think the introduction of new technology is very, very exciting. But at the same time, we need to be very cautious and evaluate the impact of that technology on health workforce workflows. So as an example, when we think back to the introduction of EMRs, they were generally thought of as an innovation that would make charting much, much easier. 20 years later and 20 years later of experience, a lot of providers will say it's the EMR that makes, which it takes up so much time and additional work. So, AIs have a lot of promise. AI scribes have a lot of promise. Telemonitoring has a lot of promise. But we need to be evaluating how these technologies are impacting workflows and whether or not they're actually making things more efficient or just making things more cumbersome.
Thank you so much. So I'm going to move to our second theme, training and retention. And so, Carol, I ask you, as the VP of Human Resources, what's your challenge, recruiting or retention?
Well, this is a big, big topic, Lauren, so I'll just say that. And I guess I'd frame it this way. As we think about recruitment and retention, it's about retention first. So how are we retaining employees, and then how are we recruiting employees? And I'll just say, through healthcare, having been in healthcare for over 40 years, this can be cyclical. Absolutely. It can be cyclical that there's lots of jobs, there's no jobs. So we see that. What's complicated that was the pandemic, and many people stayed to work longer during the pandemic. So while many people left, people stayed longer. So they maybe put off their retirement. So what we saw in 2022 at the end of the pandemic is a lot of people leaving because they held off their retirement and decided to leave, or people who had had enough of healthcare and were feeling another career option. So we're really putting a lot of focus on retention. I'll say there's, and this is well seen in the literature, that, when we lose somebody in the first year, so we hire them and they leave within the first year, there's a cost to that. And conservatively, it's around $25,000 an employee. So there's a cost for when people leave. So retaining people is really, really important. And we're sort of doing lots of things to, how do we make sure that we keep that employee? Things have changed over the years too, where employees would stay with an organization, just like many sectors, for many, many years, 40 years, not uncommon. But we know that the new healthcare, the generation of employees coming out today are looking for something different in the workforce. So they might have a number of different employers. So how do we keep that employee, and how do we motivate that employee? So we're paying attention to things like healthy workplace indicators, equity, diversity, inclusion, and belonging. Certainly we hear lots in the media around violence in hospitals. How are we creating workplaces that people want to belong to, and how do they see themselves as contributing to the larger goal of the organization? And how are they having career growth opportunities to grow within their career, different opportunities? And right now we have a lot of multi-generations working in the force, which all want different things. So we're trying to answer your question, we're tackling things on both sides. But we really do want to retain our employees, and then look at recruiting. And certainly we're looking at our students. What's that student experience like when they come to the hospital? And how do we think about recruiting some of those students who want to stay longer?
Well, how do you retain in the Department of Medicine?
Yeah,
Or
no,
recruit?
so I mean, exactly as Carol mentioned, retention is much easier than recruitment, in the sense that if you can recruit all you want, but if you're not retaining people, or you're retaining them for a short period of time, they acquire the experience that is necessary to do the job well, and then they leave, then you're not much further ahead. And I think that there's obviously a number of models that people use for both recruitment and retention. One of the big focuses is on financial incentives. And I think those typically don't work. Or if they work for a very short period of time, and it then becomes a race to the bottom. And I think some communities are struggling with that right now. But the younger generation, the new generation of healthcare workers, and this may be non-evidence based, but we have done a little bit of work on this, are very different from older generations, but in some ways they are very, very similar, in the sense that people are looking for positive aspects of their workplace. They're looking for a welcoming, supportive workplace where they can find shared purpose, shared meaning, and a feeling that they're doing something beyond their daily tasks. And I think that is the real challenge for institutions, for healthcare institutions today, is in the midst of the financial crises and the budget cuts and other challenges. How do we find non-financial ways of making your institution a destination of choice, a place where people want to come and stay, rather than a stepping stone to something else? And even if people go and train further, a nurse goes and does an MP degree, or anything along those lines, you want them to want to come back to work for you. So I think that's the key.
So, Maria, when I was thinking about this between our planning call and here, I was also thinking about healthcare used to be a career option that women were allowed into, if we think about a generation ago. So there was few options. Women could go into nursing and they could go into teaching, and in larger centers they maybe had some more options than that. Now there's tons of outside options. And so is healthcare just sort of late to the realization that their health human resources have outside options? And what is the changing role of women over the last 2 generations? How has that impacted maybe how healthcare can retain people and compete for a highly trained workforce?
So it's fantastic that women have more opportunities career-wise. In healthcare, we still see that nursing is dominated by women, but about 10% of new nurses now are men. So men are also seeing opportunities in traditionally female-oriented professions. We probably see the biggest impact in medicine itself. Women now form almost the majority of graduating classes in medicine. Right? In family medicine, women form the majority, and they have now for probably the last 20 years. That said, we need to take into account the needs of women, family physicians, women physicians in general, keeping in mind that when they start their careers, they're also at the age where they're most likely to be having a young family, that often they are also married to other professionals, that often they are married to other physicians. And so if you are married to a subspecialist, that might limit where you as a family physician are able to work, because a subspecialist will not be able to work in a small, rural community. That, during the first stages of their career, they may need to work less because they have a young family to take care of. And women, despite our career options, we still bear the greater burden taking care of our families. And so this too will change the capacity of the medical workforce to be able to take care of patients. We need to incorporate that into our human resource planning. And rather than fight it and say this is a shortcoming, this is just a characteristic of our workforce, and we would be wise to take that into account and create environments where women with young families or women or men, older men with chronic diseases can still work and contribute their skills, but feel safe and well supported, and not feel like they have to burn the candle from both ends. So again, as Carol said, creating those really supportive work environments for men and women working in all types of healthcare jobs.
And I think there's some misconceptions often in this idea that women want to work less. We're still talking about both male and female physicians working well over 50 hours a week in primary care. And so while there can be a difference between men and women in the number of hours, they're all still working far more than a full-time job's number of hours.
For many other full-time jobs.
Services. Yeah.
Yes.
So I want to ask Carol about one of the other things that Maria just brought out around rural services. Is there a way that we in urban centers can do more to support the rural communities that are so underserved? In terms of their health human resources? They can't compete on the recruiting, many of those issues that Maria just raised, but also in our desire to have communities. Our rural physicians are all often working in far more isolated settings. But is there more we can do in urban centers to support our rural colleagues?
Yeah, and I know some of the education institutes are doing this, and I was working with the School of Nursing at Western and looking at how do we create opportunities for students, or is to appreciate what happens in rural centers. It's a little bit different than in large centers. The rural nursing, certainly for nursing, looks a little different. So how can we do that? So I know that sort of supports like within the master's program, how can we help master's students do some projects actually in rural centers? Or how do we expose people to rural centers? And how do we attract people and give them the full breadth and depth of what your career could be in a rural center? Because I think sometimes, the advertising of that doesn't look so good, but there's great opportunities in rural centers too. Certainly from, doing lots of different things or that the big centers don't have. So I think there's opportunities there. And a lot of people also, as they graduate from school, they go back to their hometown where they were. So I think it's rural centers. How do the bigger centers help the rural centers in attracting nurses? How do we share resources of best practices and help support them? Because they're equally a big part of the system. If we can't move patients back to a rural center from a large hospital, that's a problem too for the system. So we're all interconnected, and I think there's a great opportunity for larger hospitals to share expertise and share resources with rural centers to help attract health professionals.
So, well, I know you have a great interest in education. So I ask you, are we training the next generation of healthcare workforce to be part of team-based care?
We're trying. We haven't yet hit on the magic sauce. So we've been trying to do what's known as IPE, interprofessional education, for close to 2 decades now. I'm not sure that that's working as well as it could. At the end of the day, I think that the solution lies somewhere between approaches to education and where people get educated. So as you know, as Carol mentioned, rural practice, like team-based practice, are things that you learn to do. And you learn them on the job. You learn them through role modeling, not necessarily only through theory, for example. And and I think that's where we're not doing as well. So I think we can do better in terms of team-based healthcare education. I'm a pharmacist by training, and I still maintain my registration with the Ontario College of Pharmacists. Yeah, I do that for a reason, because I'm very proud of that training and that education and the work that I did. But it's also because I feel it does send a message to some of my trainees that healthcare is a team-based activity, and we cannot look after people without leaning on each other, understanding each other's scope of practice, understanding expertise, supporting each other in acquiring and furthering that expertise. And so it's that model of interdependence, shared decision making, and respect that I think we still haven't figured out, how to quite impart to learners.
So, Maria, I'm going to drive you towards data for a moment. Do we know what the shortage is? Do we have a concrete estimate of the health human resource deficit in the system? What data informs that deficit, and what data gaps need to be filled? Do we know how many of each type of health human resource we actually need, and what we need maybe 5 or 10 years from now when we think about the education system around creating more health human resources?
Sadly, no, we don't have great data on health human resources. For every regulated health profession, there is a college where, as Wael alluded to, where you register every year to keep your license. That is a wonderful source of data, but sadly, those regulators don't necessarily share it to researchers or even to a pan-Canadian body that can then look at that data relation to need. So we need much more in terms of leveraging currently collected data to be able to better plan. When we plan, the traditional model has been head count. So how many nurses do we have? How many doctors do we have relative to your population? But really what we need to be doing is taking into account population needs. So how many older people, how well are they, into those calculations, and ideally also take into account team-based care. So not just be counting family physicians by themselves, but how many teams of family physicians, nurse practitioners, nurses, psychologists, all of those members to get a better understanding of the capacity relative to the needs of the population. And it's that kind of data that we truly need to be able to better plan and also better evaluate how well the human resources within the healthcare system is actually working.
Carol, do you feel like you have that data at your hospital level? If we don't have it at the macro level, do you feel like you have a good handle, not just on, what are the open positions today, which I'm confident you do, but do you know what your resource needs are going to be in 2, 3, and 5 years based on the demographic shifts that would even be predicted for our region?
We have some level of data, and we look at our workforce. Certainly, there's changes in the workforce, but it's also what people want. People are really trying to balance their work life with their home life. So for some people, that might be full-time or going to part-time. It also depends on the age of the employee. So as we talked about, certainly the workforce for nursing, female-dominated profession, in their 20s, 30s, they might have maternity leaves, which are now a year. So we look at all those things together and make sure that we're trying to plan ahead for that. But because the job market is fairly open right now, people could elect to go somewhere else where they're not necessarily staying at the same organization. So we are working closely, looking at some of our difficult to fill positions and how are we planning for that down the pipeline? How are we keeping those jobs, making sure people are working to their full scope because people want that within their profession, and providing opportunities to learn and grow. But I would say there's more opportunity for that to get a little more precision. But certainly we're following things like turnover very closely, where those areas of turnover are, why people are leaving, exit interviews, those type of things, to really understand our business and what's going to retain people within our healthcare system.
Excellent. So our last theme for our conversation is shifts in organizational models. And so, Maria, I'm going to go to you to talk about a challenging shift. So when we think about hospitals and regional conglomerates of hospitals like we have here in our region, we can see that they form a weekly coordinated structure for acute care. In contrast, primary care has never been a system. Primary care has largely been individual physicians working independent of each other and independent of pharmacists, allied healthcare, and hospitals. But newer models of team-based primary care improves the overall organization of primary care, with teams of family physicians forming small corporations together in partnership with their allied healthcare team members. However, we are now seeing private equity buying primary care clinics, imaging centers, blood testing centers. Our historical structure had the weakness of no coordination, but private equity coordination may create U.S. models of supplier-induced demand for testing and diagnostic services, meaning your family doctor sends you to get an x-ray at the clinic, also owned by the private equity firm that owns them. So why are family physicians choosing to sell their practice to private equity firms?
So when we talk about privatization, we've always had some private elements in our system. So the idea, for example, that physicians are now working for a private corporation isn't new, because most family physicians were private organizations. What's different here is that you may have a for-profit entity that is motivating styles of practice. So a couple of examples that we know about that have been documented. Out west, there are a number of clinics that offer a membership fee. So you may have to pay $1,000, $1,500 up front in order to access a family physician, right? Technically, that's not a violation of the Canada Health Act, because a membership fee is very different than being asked to pay extra for actually seeing those health services. But we should be concerned nonetheless, because what we want in Canada is healthcare that's accessible to everyone. And there are many individuals who would not be able to pay that membership fee. Another thing that we want to be really careful about is upselling. So you might go to a practice and your family physician, or the physician that you may say, along with your cataract surgery, Maria, maybe you need these special glasses and maybe you need these special drops. And when we're in that position as a patient, we're relying on that provider to advise us, hopefully with our best interest at heart. We are not in a position to say that, yes, I need my cataract surgery, but I really don't need the fancy glasses and I really don't need these eye drops. But you feel very vulnerable. And of course, you don't also want to be offending someone who is about to do surgery on you. So those situations create a lot of pressure and vulnerability for patients. And while technically within the rules of the Canada Health Act is not at all in spirit with the Canada Health Act and this idea that patients should be well informed about the choices that they are making, and they should not be incurring out-of-pocket expenses for publicly insured services, medically necessary services. And so the concern that we have when we see these private companies taking over family practices or specialist or diagnostic services is that there will be these barriers to anybody accessing these services, or that patients will not be able to take the services, feel comfortable that they are getting the services they need without this undue pressure and without these additional economic barriers.
And certainly, lots of patients are being, even within the public healthcare system, being given access to, especially on the diagnostic and genetic testing services. There are some uninsured services. And so, physicians are regularly having conversations with their patients about things that are now outside of the public system. And having to have those conversations is always, you need to be in recognition of the power dynamic and the knowledge gap. That's certainly a challenge. Well, when thinking about public-private partnerships or the move of private care into acute care services, what part of this is a demand for a product from patients versus the desperation of patients in the absence of being able to access care, and thinking about that power dynamic in the system? Is this in service of the vacuum that we've created by underinvesting, or is there really a product and an underserved marketplace?
Yeah, so I think it's both. There is healthcare, as you've pointed out in your introduction. There is an increased demand because of a population that is living longer and is living with more complex and chronic diseases, and so the demands today are certainly much higher than the demands of a decade ago, let alone 20 years ago. Our healthcare infrastructure is at its youngest, several decades old. So most hospitals have a significant infrastructure deficit, and the agility of a large system to provide bespoke or customized solutions is limited. We've been very fortunate in London that we've had the ability to have some very innovative solutions with regards to, say, ambulatory surgery, for example, with the Nazim's Kadri Surgical Center. And so that proves that the public system can adapt and can behave in differential ways to meet the challenges of certain demands. What remains, though, is a system-wide commitment to do that. Having said that, there is a significant underinvestment, and when you consider that in relationship to the growth of the population and its needs, I think that the demand is very real. As Maria mentioned, though, we have to be very careful about, is this demand being filled at the same quality and the same cost effectiveness as the public system, or are we costing the system more? Certainly, the example of the United States would suggest that private healthcare is the most expensive and least effective type of care that you can design. And so even if we move to some forms of private healthcare delivery, we have to be very careful not to simply replicate the mistakes and pitfalls that others have seen.
It seems to me that, family physicians used to run very small businesses, and now as they're being pushed into larger organizations need things like a VP of human resources and somebody to run their IT systems. And maybe the family physicians don't want to be in charge of that size of an organization. And in order to move away from management of a business and keep themselves in patient care, they're also relying on private equity to provide a system of management and to provide a human resources function and to provide technology and computer systems resources. There's clearly other ways that we could be doing that, but we might need to rely on partnerships more with our hospital systems that already have those, or through regional coordination where those can be shared resources instead of having them provided by outside agencies. And that moves me to, I think, a question for you, Carol, that's another difficult one where we've seen private entry into the healthcare system. So privatization of the health human resources themselves is affecting healthcare delivery. Nurses have a relatively strong union, long-standing negotiating relationships with hospitals, and yet we've seen nurses choosing to work for nursing agencies for higher wages, greater flexibility, work schedules, and other benefits. The cost impact of agency nurses has been high across the system. There's a big report on that in the CBC just over the last 24 hours. And so how do hospitals, home care services, nursing homes compete with private agency nurses for both the resources, but also in the context of the high cost of these services.
Yeah, and this is a big one, Lauren. And I'll just say within the London context and the London hospital context hasn't used agency nurses and very purposefully not done that. So as you use an agency nurse, they pay more wages and greater flexibility. Then you start having your staff leave their regular job to go work for the agency, come back to your hospital and work alongside of a team member making more money and not as much commitment to the organization. So as we've talked throughout this whole session, we've talked about the importance of team-based care and being part of a team. And when we use agency nurses, it's helpful for short-term help, but in the long term, it's very costly and breaks down teams and breaks down the work team together. So it's a huge problem. And I think it's really a matter of, how are organizations planning their human resources? When we try to be as efficient as we can and get right to the wire, we still need extra people in the system to help fill in when people aren't at work sometimes. And when we've gotten so tight with filling positions and can't fill positions anymore, we run into a time of not having enough people. And that's either you bring somebody in from the outside, or it might mean canceling some surgeries because you don't have the people to do that. So I think it goes back to what's the value proposition for employee working in the hospital. And I'll say throughout my career, I've had very, very good relationships with unions, and they have a role to play. And unions, represent good working relationships with the hospital to help negotiate on behalf of their members. But equally, the unions need to get to their members and say what's important to you now, and negotiate for those things. So in the past, it might look different. That was 30 years ago than what it is today. And as we talk about the new generation in the workforce, representing those members and those members actually telling their unions what they want out of a position is really important. I do believe majority of healthcare workers want to work within a hospital system and not work for an agency. Being part of a team is important, being connected to purpose for an organization and feeling you're contributing. But certainly what these agencies have offered is more flexibility with what people are looking for. And I think that's going to be the challenge for healthcare organizations, is to really think about how much flexibility can we put in the system that's helping people want to stay in their jobs. And we can do that through collective bargaining, and that system works well, but we probably need to catch up with that and spend those dollars wisely. I think it's an example of we're spending a lot of money, and how could we use that money that we're spending and do it more wisely, possibly creating extra positions in hospital to buffer that. And we also want to reduce overtime and all those things in hospitals, which are important. But it's a reality for some organizations that they are depending on agency, and we just have to make it more attractive to be back in the organization as opposed to working for the agency.
And so we've covered a lot of ground already in this conversation. I'm going to go to our questions from the audience really shortly. But one quick question for each of you. So I do say quick. So if you've got 30 seconds in the elevator with the Minister of Health, what's the recommendation that you want to first give them? What's the first change they need to make, or what's the long-term solution they need to get working on immediately? So I'll start with you, Wael. You got 30 seconds with the Minister of Health.
I do believe that, notwithstanding everything that we talked about, technology investments are important. And as one of the questions, alludes to, it's not only the investment in technology, but it is in user design technology, user informed technology, so that we are serving and improving our workflows rather than making our workflows more beholden to how the technology is set up. But there is, from AI scribes to remote monitoring to home-based monitoring, there's a tremendous good that we can get out of technology to support people that are practicing in healthcare and to improve patient outcomes.
Carol?
I would be talking about the scope of practice of each of the health disciplines and making sure those scopes of practice are working to their full potential. And that's important to the people who work within those disciplines, and it keeps them interested in their positions and wanting to continue in healthcare.
Nice. Maria?
I'm a researcher, so I'm going to say data, especially leveraging data that we already have so that we can actually evaluate some of these innovations and be able to say what works and what doesn't work. If it doesn't work, then we need to change it, but we need to base our decisions on evidence, and we can only do that if we have data that captures the issues that are of primary importance, like scope of practice or using, EMRs and technology and being able to assess that.
Thank you guys so much. I would hope that the minister finds themselves trapped with you in an elevator, each of you. So I go to our first question from the audience. So is licensure, and all of our healthcare professions are in the regulated space. So is licensure one of the issues? Can standards be relaxed to permit greater recruitment globally? And so, Maria, I want to start with you thinking about that on the primary care community health setting first, and then I'll come to you, Elle, to ask about, because I know you've got large international training programs at the hospital. Maria?
So two things. The first is we need to be cognizant that training and culture of care can vary around the world. And some things that we accept as just routine practice in Canada, such as consent and who consents and gets to make decisions, things like sexual health, mental health, the approach, the treatment, the attitudes around those can vary around the globe. And so part of licensure is making sure that the expectations that patients have in Canada can be met by their provider. I think rather than relaxing our standards, we should be working to make sure there is every opportunity for internationally trained healthcare workers to make sure that they can practice safely for both themselves as well as for the patient in the Canadian system. The other thing we need to be really cognizant of is that while working in healthcare offers the opportunity to migrate to a safer and secure community, Canada wants to behave ethically, and we don't want to rob the health resources from lower and middle income countries because they also desperately need them. So we need to be ethical in the way that we recruit, and the way that we also return to those low and middle income countries to make sure that they too have sustainable healthcare systems.
Thank you. And well, how do there are large international training programs here at Western?
So yes and no. We train internationally. Well, we train internationally sponsored residents, but those are generally residents whose governments are paying for them to train here, and then they go back and practice in their home countries. That's probably our largest population of international residents.
So they're not working here in the
They're
end.
not working here. We do have a small contingent of ministry-funded spots for international medical graduates, and that includes two populations. That includes people that have come to Canada, so they're immigrants, and it includes Canadians who have then gone to study medicine abroad, typically in Australia, the Caribbean, or European universities. And those are very small numbers. But to follow up on what Maria mentioned, I think that there is, agreeing with everything that she said, and emphasizing that there is a World Health Organization code of physician or healthcare recruitment that we're almost certainly in violation of. Within the realm of the people that are in Canada, people that have come to Canada, have been here for a number of years, there's a lot more that we can do to upskill, train, incorporate, empower people to practice some level of healthcare. And we have to be, cognizant of the fact that healthcare workers that come to Canada are probably some of the most brilliant people in their home countries. That's how they became trained as nurses, physicians, and so on and so forth. And so it does take some training, it does take some adjustment, it does take some orientation to the Canadian healthcare system, both as a practice and a culture, but we can definitely do more.
Carol, do you do international recruiting for nurses, PT, OT, RTs, the whole spectrum of allied health providers?
Yeah, we don't actively go out to recruit, but we do. The government's put out programs that help with training for internationally educated nurses. So we do help bridge that. So once an internationally educated nurse is in Canada and gets their registration through the College of Nurses, we help with a bridging program, actually. So as Maria accurately said, that sometimes it's different in different countries, some of the culture. So we help with a training and bridging program, and the government supports that. They've had a number of programs that help hospitals to help those internationally educated nurses understand the Canadian context and get socialized in the Canadian context. And we're certainly eager to bring those people who've worked with us on as employees and for more permanent work. But sometimes it just takes an in-between bridging to help those people understand, because they are, as Wael said, incredibly smart, incredibly talented individuals. And it's just understanding the Canadian context and helping with that.
So this question is a big shift. And so do you think talent, and so that's all health human resources, so broad question, are leaving the system due to infrastructure, management, or government in the system? So I think, Carol, you talked about doing exit interviews. What drives people to leave their individual position, but maybe also healthcare as a field? Right? Because moving from one position to another in your organization is maybe not as disruptive, but what's causing people to leave healthcare as a field, especially when so many people are drawn to as a calling in the first place?
Yeah, I'm just going to say, Lauren, I'm not sure I can pinpoint it down to one thing. People leave for lots of different reasons. And certainly people who join healthcare as a vocation, it's wonderful to work in healthcare. And I'll just say that as we talk about the workforce crisis, I've been a nurse for over 40 years, and I absolutely love working in healthcare and the opportunities that it has. But it's got a lot of different reasons so why people leave. So I don't think I can pin that down to one thing. I do think what's different, certainly when I certainly trained as a nurse, is that, nurses can go on to do other degrees and other things. Where I trained as a nurse, I stayed in nursing for 40 years. But a nurse might start in nursing and work for 3 years and then decide to go into policy or get a different degree and do something else. So our workforce is highly educated at this point in time and has other options to do other things. And that's just a reality of where we're at today. And that people might choose other things to do. And we need to be flexible to that. And also, as organizations, create opportunities for people to learn and grow so they'll want to stay. But some people will go and try other things. And we're seeing that in the workforce. We've talked about how people might have 3 different careers in their lives. That's different from what it was 50 years ago.
And what part of this is the barriers to get into these fields? So it used to be that medicine and Western released its acceptances this morning. The barriers to get into medicine were extraordinarily high. It is extraordinarily competitive to get into nursing, into OT, into RT, into PT. These are all extraordinarily competitive fields to get into. And so, what does the role of the barriers to this as an education system have? How I think you've had some personal impacts on this. There's these tremendous education barriers in place.
No, for sure. And it is unclear that we are getting any better of a selection than we were before. And so, I like to say that there are many people that applied to medical school that did not get in that should have, and probably as many that did that shouldn't have. Because the way we select medical students is by necessity based on something other than their ability to practice medicine or learn medicine. It's something else that we use as a proxy. I think some of the questions, some of the live questions have also alluded to this question of why are we not, with the shortage, with the massive shortage, why aren't there a lot more medical student spots? And one part of the answer is that we can't train a lot of people all at the same time. And so there are health disciplines that I'm personally aware of where supervisors/mentors are unable to manage both their workload and the training of a student. And so and health disciplines in general are practice-based training. At some point in time, you have to have practical hands-on training. And so our capacity to do that without growing this this domain is limited. And so growth, expansion has to be deliberate, has to be stepwise. Otherwise, we risk instituting learning experience that are not on par with existing ones.
It would seem to me that expanding training opportunities into rural communities meets some of the things we've spoken to. People, people want to work and live in communities that they're familiar with. And so doing your training in a community is another way to achieve that. But it's expensive as a student to have rotations in far distant communities from where you're already paying rent in the urban center where your training is housed. And so but that's not the only, that's a logistical challenge for trainees, but certainly there are also some significant challenges for the practitioners as well. And so as you think about these expansions to our training programs into rural communities, are rural communities set up to be training hubs, Maria, for all of these different kinds of new health human resources?
So I'm going to draw on my experience at my previous employer. I worked for Memorial University in Newfoundland, and of course they have a substantial rural population. And with medical students, at least, part of the training program included housing for students when they went out to a rural community. Medical students. We don't have the same infrastructure to support nursing students or pharmacists or other healthcare workers when and they don't have the same opportunities to train in rural environments. So I'm not sure whether Western equally offers housing supports to medical students, but it's one of the ways that medicine has tended to support trainees to try, to work and explore a rural setting. And I would say it's a positive because as you said, creates those opportunities so you don't have to be providing rent into places or, even finding a place to live when, you go to a small community where you've never been. Creates that sense that this community really values you and would welcome you to join their team.
Very interesting. All right, I need to wrap it up. This brings us to the end of today's Impact Live. A generation ago, working in healthcare was considered a calling, and for many, it still is today. Carol spoke to that. And our conversation today revealed to me that the great people working in healthcare are going to have great outside opportunities. And many of the things we know are essential to health resource retention in other fields are important here. And a good workplace is working in high quality teams, schedule flexibility, career advancement opportunities, leadership development, and of course, wages commensurate with the work they're doing. I know our local organizations, in many ways, thanks to Carol's terrific efforts, I've been trying to do all of those things here, and that those are really pushes that need to be happening across the community, the whole community of healthcare in Ontario and Canada. People don't want to work in places bogged down by administrative tasks and difficult to use technologies. And so really user designed EMRs that are available across the system and integrated with primary care are going to be core to freeing our primary care resources into patient care. Solving these challenges with very constrained financial resources are really a deficit of investment from our provincial governments over many, many, many decades now, while still centering patient care is an extraordinarily difficult challenge. And so I'm so grateful to these three people because I know that they are working as every part of their day-to-day jobs in that effort. They spend additional time and effort trying to create more systemic solutions for healthcare. And for that, I'm grateful. And of course, I'm grateful for their willingness to share their knowledge and insights with the Ivey community today. So we thank you. I also thank our audience for tuning in today. And if you'd like to revisit this discussion or share it with your network, a recording and session summary will be sent to your inbox next week. Please keep an eye out for that. And before you go, we'd greatly appreciate if you could take a moment to complete the brief survey that will appear as you exit the webinar. Your feedback is vital in helping Ivey communicate helping Ivey shape the future events that reflect your interests and priorities. Thank you once again, and we look forward to seeing you again at future Impact Live webinars. Take care, and I'm just so grateful. Thank you, Maria, Carol, and Wael.
Thank you.